Thank you for inviting me to talk about pros and cons of early cannulation grafts. I have no disclosure on this topic. First, I would like to share with you a lesson. In the early 90s, a new early cannulation graft was presented by Gore named Diastat. The graft was made of standard grafts, covered with 2 layers of crossing fibers and strips that aim to seal the needle hole after needle withdrawal and stop the bleeding immediately. All of these layers were covered by a thin layer keeping the graft intact. There was enormous enthusiasm from these grafts, and many surgeons used it for their near and dear patients, including your humble servants. Unfortunately, while the graft has exciting promise, we experienced a very high rate of thrombosis compared to standard graft. Thrombectomy results were poor, and we didn't understand why we can't open them. A few years later, this study was published, reporting poor results of the Diastat, in contrast to the published studies by Bartlett, Gelfrich, and Taucher. In the attached picture in the article, you can appreciate that no cover material is present on the graft. Arrow indicates site of needle dislodgement. It is difficult to understand what is going on, and I will explain it later. It appears to us that 8 of 20 Diastat grafts thrombosed versus 1 only in the standard graft within less than 1 month, and 4 Diastat infection versus 0 standard graft infection. Even then, the conclusion was very gentle. The Diastat does not appear to be ideal hemodialysis access grafts, and I would say it was a disaster. So, what happened here? Since the covering layers were not stuck to the grafts, at needle withdrawal, the blood leaked between the layers, causing acute bulging of the graft to the inner lumen that led to thrombosis. Thrombectomy was doomed to failure, and when we used it, that was uncorrectable. In spite of the alarm, 7 years later, many centers were still using this graft, as published at this article in 2003. You can see here that the Diastat was significantly inferior to the standard graft, so thus passes the Diastat glory. I carry this lesson in my heart. We would always wait for large-scale trials that confirm the promise of the industry. Just to understand how we construct every graft, you can see here how the graft looks like prior to creation, and here the graft is after tunneling, before and after anastomosis. 10 days post-op, the graft is ready for cannulation, but it can be used earlier. It took several years from the Diastat adventure for another wave of new early cannulation grafts. The technology was improved with insertion of sealing material between the layers. On the shelf appeared Flexen, AVflo, Vectra, Rapidax, and Acuseal, and any other that I don't remember the names. In 2015, a systematic review of all early cannulation grafts was published in JVA by El Shakarchi, and the conclusion was, our review showed that early cannulation is possible without detrimental, but that it did not allow specific graft recommendation. 4 years after the first systematic review, El Shakarchi et al. Published updated systematic review with the same conclusion as the previous one, except the fact that AVflo, Vectra, and Rapidax were removed from the shelf due to multiple problems. But in spite of that, the authors claims that they are adequate grafts for hemodialysis. Moreover, infection rates of up to 18%. It's very high and definitely not relatively low, as the author claim. Let us talk about the Rapidax, a 3-layer graft that was included in El Shakarchi article. As I mentioned previously, I am always suspicious with new devices. Soon after we got it in Israel, patient with failing Rapidax graft referred to us for revision. This is a Rapidax graft created few months ago that already had thrombosed twice, and the patient still with permacut. You can appreciate the severe destruction of the wall with extensive separation of the posterior wall. We saw kinking of the graft when crossing the elbow that we have never seen in standard graft. Fortunately, this graft is not on the shelf anymore. The Acuseal is the most popular early cannulation graft. The industry promises us an uncompromised handling with 3-layer sealing properties, with cannulation within 24 hours. In order to allow early cannulation, the graft should have an immediate sealing after a needle withdrawal. This is achieved by 3-layer design with middle graft layer of elastomeric material between the outer PTFE and the inner layer, probably silicone-based. As you can see in this slide, you should always imagine that the needling will act like a biopsy needle and fragments of the silicone may flash into the lungs. The patency rate is better than the historical results, but there are prospective studies with better results using heparin-bonded standard grafts. You can appreciate that only 20% of the graft cannulated within 24 hours, unlike their promise, and only 50% of them were cannulated within 1 week. This is one of the first studies published in JVA with secondary patency rate of 93% at 6 months, with 10 patients at risk and 68% at 12 months, with only 3 patients at risk. Really, I don't understand what is the value of 3 patients at risk at 1 year. It is well known that 20 to 30% of the grafts will not require any intervention at the first year at all. The first randomized controlled trial and cost-effectiveness analysis of early cannulation AV grafts versus tunneled central venous catheters in patients requiring urgent vascular access for hemodialysis was published in 2017. There was a significant advantage in the use of early cannulation graft with less infection rate and lower mortality. This is another study of 141 Flixen graft with 83.6% secondary patency, which is good outcome for graft. The authors believe that early cannulation graft provide a useful addition for vascular access surgeons, preventing the use of tunnel line and providing more flexibility in the timing of placing a graft for hemodialysis. In this study, there were 2 groups. The elective in red line with 60% secondary patency at 1 year, and the emergency with 50% secondary patency in 1 year. In my calculation, the average of both of them cannot be higher than 60%. But in this figure, all Flixen graft is suddenly reached near 84% secondary patency. Please forgive me, but I don't understand this meta calculation, but I assume it is a typo mistake. For comparison from our experience, Propaten graft reached 83 secondary patency at 1 and 2 years, and 80% secondary patency at 3rd year. That's how should the graft Kaplan-Meier graft look like. One of the advantages of early cannulation graft is that pseudoaneurysm formation did not occur in any graft within the first 13 months after implantation, but it is not comparative study, and usually pseudoaneurysm doesn't develop within that short time. In this study, comparing 45 Flixen grafts versus 19 standard grafts, there was no difference between the 2 groups. 78% of early cannulation graft cannulated within 3 days. This is very impressive. On the other side, there was high rate of infection, 20% with Flixen and 40% in the standard graft that require graft removal. But the most important issue is avoiding central catheter, but this was not reported in this study at all. In this retrospective study, 143 Acuseal grafts compared to 161 standard AV grafts. Median time to first cannulation was 3 days in the early cannulation graft and 30 days in the standard graft group. However, there was no significant difference in patency, thrombosis and infection at 12 months between the Acuseal and standard graft. However, there was no significant difference in patency, thrombosis, and in infection at 12 months between Acuseal and standard grafts. The pros of early cannulation graft are higher rate of early cannulation, 52% graft cannulation within 3 days. In another study, the median time to first cannulation was 3 days in the early cannulation graft compared to 30 days in the standard graft group. In another study, 78% early cannulation achieved within 3 days, but with 20 to 40% infection rate, which is huge. The total cost of care per patient was higher for AV fistula compared to early cannulation graft at 1 year due to secondary intervention and CVC complication, but the issue is comparing between early cannulation graft and standard graft, not AV fistula. We know that many centers have a poor outcome for AV fistula creation. For example, the clopidogrel study from USA, where 60% of the fistula failed to mature. Such centers will have a distorted outcome. The cons are expensive early cannulation graft price. There is no significant difference in patency nor thrombosis between early cannulation graft and standard graft in all papers. Unfortunately, after 10 years of early cannulation grafts, there is no decent prospective randomized clinical trial comparing early cannulation grafts and standard grafts, and there is no study with more than a year of follow-up. I think we should be ashamed for this. In our practice, we allow early cannulation of the standard graft at 10 days and less than that. We don't use early cannulation graft at all. These are 2 patients, 10 days postoperative, that can start dialysis without any problem, even earlier. There is no edema, the graft is easily palpated with tissue incorporation to the graft. In our real world, 80% of dialysis patients require urgent central vein catheter. So even with early cannulation graft initiating cannulation in 3 days and standard graft initiating cannulation at 10 days, the difference between the 2 groups is 7 days only. 20% pre-dialysis patient can have preemptive AV fistula that can be created in advance prior to initiation of dialysis and doesn't require any early cannulation graft at all. A decent prospective randomized clinical trial of those 80% patients with CVC should be planned comparing between early cannulation graft and standard graft within at least more than 2 years of follow-up. Then we may know which approach is better. Unfortunately, most of the study in this presentation and in the literature suffer from very low-level evidence and very short follow-up. Thus, I cannot justify the use of early cannulation. Thank you so much for your attention.